It's 12:31. So I'm truly honored to be here, and thank you to all of you for giving me this time. So it's a privilege to be in front of you, and because it's my own group of friends, I've been exceedingly nervous about this whole presentation. So I've had my supporters all around here, so the moment I feel nervous, they're going to get up, stand up and start clapping. So Dr. Turakia has he's my neighbor, and I keep going to his house and keep bugging him with these slides and say, BT, what do you think about this and all that? So this journey that I'm about to go through with you started probably about 2.5 years ago. So Dr. Lou Clark is there out there, and he and I used to have arguments as to how good and bad statins are. I was on the good side and he was on the bad side. So in any case, so it took me really 2.5 years of really hard work to come to this point. And I remember that 2.5 years ago, we had a conference in which we were discussing that every patient post-MI should go home on a statin. And I was trying to challenge that, and many of my colleagues, some of the great minds out here, the big bosses of this place, and my friends, Dr. Saman and Dr. Shah, challenged me that no, everybody after MI should have a statin. And that gave me a lot of incentive to look into this. So usually when I talk to my patients, I talk to them about insulin resistance, metabolic syndrome. But today, because you all are here, I'm going to do a little different and focus on the diet, cholesterol, statin, heart disease hypothesis. So it goes like this, that dietary fat and cholesterol is an important component of cardiovascular disease. The more saturated fat you eat, the higher your cholesterol and higher your heart disease. So the way it started was that Ansel Keys is a physiologist out of Minnesota who did a study back in the 50s to 70s, which was called the 7-country study. And what he did was that he went to different countries and saw how much fat they were eating. So the greater the percentage of fat they were eating, he found greater the risks of heart disease. So Japan at the end of World War II was eating very little fat, lower incidence of heart disease. US was out there, Canada, Australia. So in the 7 countries, he showed a linear relationship between saturated fat and heart disease. So, and this is what I took from the USDA website last year. It says intakes of dietary fat and cholesterol are major determinants of heart disease and diabetes, and that in order to reduce these diseases, there are health benefits of limiting saturated fat and cholesterol to less than 7% of total calories. So this is there, and even today on the American Heart Association website, there is significant recommendations to reduce saturated fat. So if George Bernard Shaw heard this is what he would have said, that no diet would remove all fat from your body because your brain is almost entirely fat. Without the brain, you might look good, but all you could do is to look like Donald Trump. So that gives you my political affiliations also, okay? So we've evolved over 2.5 billion years, and we managed to remain lean and muscular all this time. And it's only in the last 50 years, maybe people can say 100 years, that obesity has come upon and metabolic syndrome has come upon so strongly. So if you go back to the Paleolithic era, we used to consume high amounts of animal food. And it was not just animal food. What we ate was the fattiest part of the animal. When we would kill the animal, we'll eat fat from it, the tongue, the organs, and we'd leave the lean part for the scavengers. So the amount of carbohydrate we eat, I apologize for people who are vegetarians out here, because the talk might not be that good for you all. But anyway, the amount of carbohydrates we ate was really very complex carbohydrates that involved seeds. There were absolutely no grains. And the fruits that our ancestors ate were bitter and tart. They were not these genetically modified sweet fruit that we eat now, which are high in fructose. So this slide just shows you that industrial revolution and farming is only about 10,000 years old. That's a blip in time. And processed food really is about 50 years old. So, but what I wanted to show you was that Ansel Keys, the 7 countries guy, was so convincing that American public said we need studies to show an association between saturated fat intake and heart disease. So in the 1950s, 60s, 70s, 80s, 90s, multiple different studies were done to show an association between saturated fat and heart disease. And I'm going to take you guys way back. But bottom line is that I challenge anybody in this audience, anybody anywhere, to bring me one single study that shows that intake of saturated fat increases the risks of heart disease or diabetes. There is not one. But let me take you through some of them. This is the Women's Health Initiative. Almost 100,000 postmenopausal women. Half of them were given an advice of low fat, high grains, fruits and vegetable diet. The other half were on the regular diet. We spent almost in today's dollars, close to $500 million to $750 million on this project. And at the end of 6 to 7 years, it's actually 8 years of follow-up, there was absolutely no difference either in the incidence of heart disease, strokes, or cancers. No difference after more than $500 million spent. Let's look at men. Men went through what was called the Mr. Fit trial. In order to select 12,000 men, roughly 360,000 men were screened. And only people with with cholesterol levels over 250, somewhere in the range of 280. And they were said, your cholesterol level is so high that you would be probably pretty close to your deathbed. So they were assigned, so these near-death patients were assigned either to a low-fat group and also smoking cessation and hypertension treatment, or the other guys were said, just go do your usual care. We don't care how you do, just do what you want to do. So Wall Street Journal came back and said at the end of 1982, which was basically about 7 years, that there was no difference in mortality, MIs. Roughly 274 patients in the intervention group died, 270 in the control group died. So really, Mr. Fit trial was a total bust. So that's when we started realizing that Ansel Keys was doing that what most academicians do, what most researchers do. He had data about fat and heart disease from 22 countries. But he chose to show only the 7 countries that fit his paradigm. He ignored the data from the 22 countries because when you look at the 22 countries, it's a scatter plot. And I can take these same 22 countries and select my 7 countries and show that there is an inverse association between fat intake and heart disease. I can put France and Netherlands at the bottom out here and put a few other countries out there from South America and say, hey, higher the fat intake, lower the risk of heart disease. Now this is a statement from George Mann, who was an associate director from Framingham Heart Program. And this program is still ongoing. He said that the diet heart idea is the greatest scientific deception of our times. And it took me several years to figure that out. This is another gentleman, William Castelli, who is also a director of the Framingham Heart Study. And he says, and this is actually reported in the Archives of Internal Medicine, that the more saturated fat one ate, the more cholesterol one ate, the more calories one ate, the lower the person's serum cholesterol. We found that the people who ate the most cholesterol, most saturated fat, most calories, weighed the least, and were the most physically active. So what happened? We go back into the 1950s, 60s, and 70s, and this is what is called the Nanes diagram of the United States, NHANES. So what you're seeing out here is a map of the United States, and obesity rates are shown by a specific color, And out here in Texas in 1989, we were about 10%. When the recommendations from the McGovern Committee, from the government, from American Heart Association was that, hey, what we want you to do is to reduce the intake of your fat, eat more carbs. So Americans did that, and we succeeded in fattening up the country quite effectively. So we are at about 35% out here in Texas and Louisiana. So if I make 3 people stand up in an audience, 2 of them will be either obese or overweight. 68% incidence of increased weight in this country. So this is what we say. And what this says is that we have had to modify the picture of Barbie, because now Barbie has to show a little butt and a little metabolic syndrome, the little belly. So 90s were coming along, and what they found is that the diet heart hypothesis was not making any progress. So they said, hey, fat reduction is not helping, but we can reduce cholesterol with medications. And by this time we got to know about LDL. Up until then it was only cholesterol. So they said, we're going to reduce cholesterol with medications, with drugs, and we're going to show a heart disease reduction. So the older guys in the audience, like me and Dr. Turakia, will recognize that initially the trials that were started with the Lipid research clinic trials, the WHO project, and these trials were done with clofebrate and with the bile acid binding resins. So 3 multiple studies. The Lipid research clinic study actually cost the taxpayers about $500 million. They took 4,000 patients, but in order to get 4,000 patients, they screened about 500,000 patients, because these people had the highest cholesterol, about between 250 and 280. They reduced cholesterol by about 19%. LDL cholesterol was reduced by 19%. There was absolutely no difference in either mortality or myocardial infarction in any of these 3 studies. So then came this blockbuster trial. And this blockbuster trial is called the 4S trial, the simvastatin Scandinavian study, or Scandinavian simvastatin trial. So it was a resoundingly positive trial in showing the reduction of death and myocardial infarctions in patients who were on statins. But before I get into that, I want to take you through a little bit of a journey. So I don't know if any of you know the Vioxx affair from 2005. But in the Vioxx affair, Merck paid the government $5 billion. Now, the reason it paid $5 billion is because there was a jury in Angleton, Texas, which is not far from here, that awarded $300 million to a woman whose husband died of a heart attack. So Merck did a data dump to the lawyers. So when they asked for internal documents, they did a data dump, and they felt that these guys are never going to find out. But anyway, the Texan lawyer was pretty smart. And what he found was that in Merck internal documents, they already knew that since this was a COX-2 inhibitor, that it was increasing thromboxane activity. So prostacyclin thins the blood, thromboxane thickens the blood, and COX-2 inhibitors increase thromboxane activity, so increase the risks of myocardial infarction, and Merck already knew that. Merck withheld this information from FDA. Then in 1999, Merck started a study called the Vigor trial to show the superiority of Vioxx over naproxen. They said naproxen is going to cause GI upset, Vioxx is not going to cause GI upset. We are already getting 22,000 prescriptions written on this drug. It was a blockbuster drug. So they started the study, but soon found out that people in the Vioxx group were having a higher incidence of heart attack. So whenever you do a clinical study, you have a data safety and monitoring board. So the only purpose of data safety and monitoring board is to stop the trial if a safety endpoint is reached. So really, you need to keep that in mind. You stop a trial if the safety endpoint is reached. You do not stop a trial if an efficacy endpoint is reached. It's safety that you're concerned about because you're treating it with usual treatment. So when they found this out, they kind of bribed the guy who was the chief of the Data Safety and Monitoring Board, and they gave him a lucrative contract that was to start right after the Data Safety and Monitoring Board was to finish their activity. The next thing that they did was they presented efficacy data for 36 months. So in other words, the benefit of the drug was presented for 36 months, but the safety was stopped at 35 months. Because in the last month, there were 4 or 5 heart attacks. They wanted to get rid of that so that the Vigor trial would not look good. So that's why they ended up paying a huge amount of fine. Now I want to take you through the ENHANCE trial now, because these trials are very crucial in understanding how pharmaceutical companies and drug company sponsored research works. So ENHANCE trial was a trial of Vytorin versus Zocor. Vytorin is a combination drug that reduces cholesterol a lot more because of synergistic effect between two drugs compared to Zocor. So this trial was done in people who are called familial hypercholesterolemia. So people with familial hypercholesterolemia have cholesterol levels that are about 2.5 to 3-fold normal. So these people are considered to be at very high risk of having coronary artery disease. So roughly 1,600 patients were enrolled. A lot of fanfare was done because several people had done all kinds of IVA studies, which is intravascular ultrasound, to show plaque regression. So this was to evaluate plaques in the carotid arteries. Study was launched in 2005, 2006, was supposed to get the results, and Merck was not publishing the results for 2 years. So people had to ask them, and ultimately FDA had to force them to show the results. So what I want to tell you is that when you have a drug company sponsored study, until the new trial regulation that came on with the ENHANCE trial, a company could do 10 studies and make public only those studies that were favorable to the drug. So in other words, I could do 10 statin studies and show only the 2 that came out positive, and I could ignore the other 8. So it's only after the ENHANCE trial that drug companies, when they do a trial, have to publish at least on the internet. The data is collected almost exclusively by the drug company employees. You know, in these days, mega studies are done at 1,400 centers across the world. Which academic institution will have the wherewithal to go and collect this data? They are in-house statisticians. Almost every single study is written by ghostwriters, people employed by the company that write the study and then just give it to the academicians to just publish. So anyway, this is the ENHANCE trial. I already took you through that, Vytorin versus simvastatin. There was a 25% greater reduction in cholesterol in the Vytorin group, but in the end what we found is that there was no difference in the carotid intimal thickness. There was no change in plaque size at all by using simvastatin. Okay, so I'm going to get back to the 4S trial in a bit. I just want to make sure I don't run over, so I'm timing myself. So before I go to the Vioxx trial, there was a trial which is called the Treat to New Targets. This is is anybody here from Cleveland Clinic? No? You are. So there's a gentleman out there by name Steve Nissen, who is a statin-holic, but anyway, he runs most of the trials for Pfizer. So he did a trial, this was in the post-Vioxx era, Treat to New Targets, in which there was either 10 milligrams of atorvastatin or 80 milligrams of atorvastatin. This is popularly called Lipitor. So 10,000 patients. In the higher dose of Lipitor, there was a 34% more reduction in LDL. But when you looked at the number of deaths at the end of 4.5, 5 years, what was found is that there was no difference in deaths. So you are getting a more dramatic reduction in lipid levels and no difference in deaths. So let's take the IDEAL trial. IDEAL trial is a statin versus statin trial, 20 milligrams of simvastatin versus 80 milligrams of atorvastatin, again post-Vioxx. Merck was watching this group, Pfizer was watching this group. 8,800 patients, 30% greater reduction in LDL. What happens to death? Almost no difference. So in other words, this graded response, greater the reduction in LDL, greater the benefit, all fell by the wayside. So this is the FOREST study. The FOREST study, 4,444 patients. At the end of 5 years, the difference in mortality was about 0.6%. So about the difference at the end of 5 years was 3% between the treated group and the control group in the pre-Vioxx era. So there was another trial which is called the Lipid trial done with pravastatin, came up with the same benefit, about 9,014 patients, 0.3% difference per year over 5 years, so a little about 1.9%. So the reason I'm showing is that these are perhaps the only two positive trials that you can come at in terms of lipid lowering, in terms of mortality benefit. Because the only verifiable event in a clinical trial is how many people die. And even in that, the FDA never checks how many people die. They just take the data supplied by the drug company.
Dr. Ali, I noticed you mentioning mortality data on every study, but a lot of these call more the MI rate, the event rate. You didn't comment on the event rate.
I'll comment on the event rate, but yeah, I just said that the event rate is that the only verifiable data is really the mortality data. But even if you look at a combined endpoint, in my mind, the way I answer that question is like this. If you have to do a 10,000 patient study to show a 1% difference in a combined endpoint, that's a ridiculous study to do. So 1% absolute difference. So really, almost all the studies, although they show some difference in combined endpoint, the combined endpoint is never really verifiable. Okay, but just look at the totality of data. Okay, so this is the FOREST trial, this is the Lipid trial, 25 to 35% reduction in LDL cholesterol, 3.3 to 1.9% reduction in mortality. Here is 2005 and 6, Vioxx and Enhance. Trials done after that, similar reduction in cholesterol, no change in mortality. Okay? Now, Charlie is here, and I asked him to come. This is data on diabetics. So there was a trial that was done in the pre-Vioxx era called the CARDS trial in patients who got atorvastatin and diabetics. So sponsor, Pfizer, was present, roughly about 3,000 patients. This is one of the things that keeps happening these days, which is called early termination. So in other words, they have data safety and monitoring committee, which are nothing but paid people who are statin favorable for the company. And they keep looking at data every few months to stop the trial as soon as significance is reached in a combined endpoint. But in any case, despite all of these issues, the difference in mortality was 4.3 in the Lipitor group, 5.8% in the control group, pre-Vioxx era. The p-value was 0.059, so it's at 0.06. So I would say borderline statistically significant. But you should have consistency of data. The data should be repeated. So this was a trial that was done post-Vioxx, and it's called the 4D trial. These are diabetic patients who are also on dialysis. So Mahendra will tell you that dialysis patients are such that their data cannot be manipulated easily by drug companies because they are followed very closely by their dialysis physicians. And 1,200 patients who were definitely higher risk than the CARDS group. There was no early termination, 20 milligrams of Lipitor versus placebo, no reduction in death, no reduction in MACE. So despite higher risk, no benefit. Okay, let's keep going. This is called the ASPEN trial, non-insulin dependent diabetic patients. This was also post-Vioxx. And this is the reason I'm putting this out is because whenever a trial is negative, what happens is that it gets dumped into a low impact journal. In a journal in which nobody will look at. I never heard about diabetic care, and I don't know if Charlie did. But nobody looked at this trial, but basically with 2,400 patients, with Lipitor versus placebo, there was absolutely no difference in mortality despite a 30% reduction in LDL cholesterol, no reduction in death rate, no reduction in MACE. Okay, so I am summarizing the diabetic data out here. CARD seems positive. It was pre-Vioxx era. 4D and ASPEN, probably better controlled. Post-Vioxx era are negative. Okay, now I don't see a neurologist out here, but This is another bad thing I think we do, and that is every stroke patient, we put them on statins. And I'm really not sure what is the data for that. Because if you look at Japanese people post-World War II, they had a dramatically low cholesterol levels compared to the Americans. The incidence of stroke in Japan was 25-fold higher at the end of World War II. As Japan became affluent, as they started consuming saturated fat and animal products, their cholesterol went up. Their stroke rate did not go up. Their stroke rate dropped off a cliff. So based on meta-analysis, based on subgroup analysis, we are almost forced to give everybody having a stroke a statin. So Sparkle is the only trial that was done that was directly looking at stroke patients. It was done in the peri-Vioxx era, so it was done between 2003 and 2006. About 5,000 patients, 205 centers, 80 milligrams of Lipitor versus placebo. I don't know what this does to cognitive aspect of somebody who's having a stroke, and I'll show you cognition effects of statins. Anyway, the trial duration was 5 years. There were more deaths in the Lipitor group than in the control group. And at the end of 5 years of analysis, the difference in stroke rate was 1.9%. So basically, the difference is about a little over 0.4% per year in reduction in stroke. This is absolute risk reduction. Okay, now many people out here take Crestor, I know that. Now Crestor was launched with $1 billion in advertising. $1 billion in advertising. So this is the Jupiter trial done in about 18,000 patients, 9,000 in each group. These people were low risk, they had low cholesterol levels, and these people had high CRPs. So the study was done at 14,000 centers. The sponsor collected the entire data. The sponsor had the statisticians. So when they presented the mortality data, the mortality data was different that was given to the media, that was presented at AHA, that came out in New England Journal of Medicine, and what was submitted to the FDA. So there were 5 versions of mortality data in there. Now, I don't know, I want you to appreciate this, this slide out here, because this is cumulative incidence, that's 1, that's 0, and this is the difference in mortality between the two groups. Can you make any difference other than saying that the two curves are superimposed? But anyway, you know, see how you have to expand that curve? It's not even going up to 0.1, it's going to 0.08. And what they are showing you is that the placebo had a slightly higher mortality, and the difference was 2.2% versus 2.7%. A difference of 0.5% in terms of mortality in a trial that was stopped at 1.9 years because of repeated interim analysis to show that, hey, we have reached the endpoint, now we can stop. They had no safety issues, it was just the endpoint. And the safety issue that was happening was that many more people in the Crestor group were becoming diabetics. And they didn't want to ignore that. They just wanted to ignore that. Okay, so let's say Crestor you believe is highly positive. It's, the Jupiter trial is good. You're happy with having a difference in mortality of 0.5%. But there should be consistency in the data. The data should be consistent in Crestor. So next study that was done was the Corona study for Crestor. The Corona study was ischemic heart failure patients. These are very high risk patients because they would have higher endpoints. They had higher risk of having an MI. So in this trial, 5,000 patients, ischemic heart failure, 10 milligrams of Crestor versus placebo, no difference in mortality, CV mortality or MI. So that goes to Alfred's point. It's not just death, but it's a combined endpoint that's showing no benefit. Then came the GISI heart failure trial done in Italy. These were also ischemic heart failure patients, 3.9 years of follow-up, 5,000 patients, no difference again in mortality, CV mortality, and MI. Okay, then comes the Mahendra group, the patients on dialysis, the Aurora study, about roughly around 2,700 patients, Crestor versus placebo, 43% reduction in LDL, 4 years of follow-up. What did you find in renal failure patients who were on dialysis on Crestor? No difference in mortality, no difference in MI. So if you ask Dr. Rashid, he will tell you that right now the indications for statin is not a cholesterol level. It says treat risk, not level. Higher the risk, more the reason for these people to get treatment. So these are the lowest risk people in Jupiter. The Corona, the GISSI, the Aurora, the renal failure patients, these are the highest risks. You should get benefit here that is greater than benefit here. What did we find? A puny little benefit here and no difference in any of the cardiovascular or mortality endpoints out there. So I borrowed these slides from Dr. Malcolm Kendrick, who is one of my heroes. He says, how do you use statistics to deceive? I shall pose you a simple question. What are the chances of winning a jackpot in a lottery? About 1 in 15 million. If I were to improve your chances from 1 in 15 million to about a massive 1.5 in 15 million, I could claim that I have increased your chances of winning by 50%. 50%, however, represents a relative increase in your chances, but the absolute increase is 0.5 in 15 million. In other words, that's 0.000003%. So here, I'm advertising you my services. I'm a lottery expert. Do you want to be a millionaire? If so, world-renowned lottery expert, Nobel Prize-winning mathematician Dr. Ali can increase your chance of winning the lottery by 50%. Yes, 50%, you can be a winner. Just send $10 in a self-addressed staff envelope. This is no con trick. This is guaranteed to work. On the other hand, I should not advertise my services like this, that the pathetic, desperate, lonely, rather hard up Dr. Ali can very slightly increase your miserably small chance of winning the lottery by a meager this much. And yes, pitiful, isn't it? You pathetic, sniveling toe rag, you get the message. So the truth is that we have abdicated our clinical responsibility. We take relative risk reduction and push drugs. What we should be looking at is absolute risk reduction in any clinical trial. Now, okay, I'm good on time. What I want to tell you is that in the last section is to talk about how we are misled into thinking that LDL is all bad. So if you look at an LDL, when you get a cholesterol level, you're really not getting a cholesterol level, you're getting a lipoprotein level. So lipoprotein is a very complex molecule because it's got a phospholipid bilayer, it's got apoproteins or some type of protein molecules, and it's got some cholesterol in the phospholipid bilayer also, but really the cholesterol is in the center. But that's not what LDL carries. The LDL carries CoQ10, vitamin E, vitamin A, several antioxidants, zinc, vitamin K2. So this is an important carrier molecule, and we think that the lower we reduce the LDL, the better it is. But what we are ignoring is the tremendous amount of literature that is out there that shows that people with high LDL, especially after age 50, because if you look at LDL levels go up as we get older. So people with high LDL, especially after age 50, have better memory, better cognition, better mathematics skills, lower risk of infection, lower risk of cancers, and a longer survival. Why are we ignoring all of this? Okay, now we know that cholesterol is needed in every cell in the body. About 25% of the body's cholesterol is in the brain, and that's why George Bernard Shaw made that comment. But if you look at the Smith-Lemli-Opitz syndrome, which is a group of kids that are born without the ability to make cholesterol, they have a stillbirth. They have a stillbirth. Now, if I take one of the psychiatric patients, fortunately no psychiatrist here, if I reduce their serum sodium levels by 10%, they would have a high risk of dying because their brain will cave in. On the other hand, familial hypercholesterolemia people have lipid levels that are 2.5 to 3-fold normal. 2.5 to 3-fold normal. And if you look at the Simon-Broom study, if you look at the whole cohort of patients, their survival is no different than a normal cohort. They live up to 100, 104. Oh, if he had maybe slightly lower cholesterol level, maybe he would have lived up to 110. So, in other words, no cholesterol, you die. 3-fold higher cholesterol, your lifespan is no different. I want you to understand that there are 29 billion reasons to lie about statins, because that's the amount of profit that the statin companies make every year. There is no point in them looking at cognition, memory, sexual dysfunction, because of course the sex hormones come from cholesterol. Vitamin D comes from cholesterol being changed in the skin into vitamin D. Peripheral neuropathy is very common. Joint and muscle injuries, I won't even get into that. But there is something I'll get into, which is malignancy. So it's like asking big tobacco to fund a study on lung cancer. Anyway, so CoQ10 is a very important component of cholesterol metabolism. CoQ10 comes from cholesterol. So when you stop HMG-CoA reductase, you also stop the production of cholesterol and CoQ10. Now, I'll take you back to your medical school, and I'll take you through the Krebs citric acid cycle, which is connected to the electron transport chain. And the electron transport chain needs a cofactor to change ADP to ATP. What is that cofactor? That cofactor is CoQ10. Okay, I want to take a minute to go through Illuminate trial. Illuminate trial was a trial in which people were given Lipitor plus another drug that raised the levels of HDL quite dramatically. It was an experimental drug. So this is the Lipitor alone arm in the Illuminate trial. You see that the LDL levels on Lipitor are about 79 to 80. The HDL levels are of about 50. Okay? Now this is the arm that got the HDL increasing drug. You can see that the HDL levels went up to 70 to 80, and the LDL levels came down to 58 to 60. Nothing could be more beneficial. You're increasing the good cholesterol, you're dropping the bad cholesterol. What do you think is going to happen? The study had to be stopped prematurely because the mortality was almost double. Cancer mortality was higher. Hospitalizations for congestive heart failure were higher. Makes sense. When you stop CoQ10, patient CHF is going to get worse because the heart muscle needs the most CoQ10. So what I want to show you here, this slide you may not be able to see, but the greater the reduction in LDL, greater is the cancer risk in this meta-analysis done by Al-Sheikh and others. And if you are interested, I can show that to you in more detail. I won't be able to go through the Golem studies that show you that there is definite evidence of cognitive decline in patients who take statins. This is Dr. Dwayne Graveline. He wrote a book called Lipitor, Thief of Memory. It's a very interesting read. All of us should read that. Okay, so I gave myself an impossible task to do. So it's 1:09. I'm going to speak for another 10 minutes and then stop. So is that okay with you guys, or should I stop here? No. Okay, so I want to tell you that the data on eating fat and having higher level of cholesterol from an epidemiologic standpoint is pretty damn good. So this is the Monica project, 2008. It shows the amount of fat consumption per gram in European countries, and you see that France and Italy and Sweden are the higher fat consuming countries, whereas the Azerbaijans, the Russian republics consume less fat. So you would expect countries consuming more fat to have more heart disease and strokes. But the map is the exact opposite. Okay, so it's an exact opposite map. People consuming more fat are having lower strokes and lower heart disease, and people consuming more fat also have higher cholesterol levels. So if you look at cholesterol levels in this population, their cholesterol levels will be higher. Okay, I have been doing this for 2.5 years. I put my patients routinely on a low-carb, high-fat diet. And I see consistently that when these patients come back, that their biochemical markers that show the quality of their lipids improves, their HDL goes up. There is a dramatic reduction in triglycerides. We'll talk about the LDL in a little bit. Their insulin levels fall. Their saturated fat is same as triglycerides, and many markers of inflammation go down. The way I would put it is like this. I see in my patients that HDL is going up, triglycerides are going down, and the LDL becomes the large and fluffy kind. In about 1/3 of people, the LDL remains the same. In 1/3 it goes down, and in 1/3 it goes up. But almost everybody who's going on a low carb, high fat diet, and when I say high fat diet, I talk about saturated fat, I talk about animal fat, I talk about cheese. Because I say if you are really a vegan, you're basically SOL from my group. So what happens in people who are taking high carbohydrate diet is that the triglycerides are high because VLDL production goes up in the liver, their HDL goes down, and their LDL becomes small and dense. And this is associated, if you measure CRP in this group, it will be high because that's what causes inflammation. So I didn't take you through studies for lack of time, but right now this number is 30. There are 30 studies with low carb, high fat diet that show that they're 30 to 0 for weight loss. They all reduce triglycerides, they all increase HDL, they all drop hemoglobin A1C, they all drop insulin levels, they all change the HDL to large and fluffy, they all reduce markers of inflammation. And I don't need to show you any studies. You can come and look at my practice. I have Nina out there, I have Brandy out there, I have Melissa out here. These people are galvanized by seeing my patients improve. And one of my biggest supporters, Jana, is also out there, and she also sees that she's made so many recipes for a low carb, high fat diet. So what did we do for the last 30 years? We've asked people to go with the food pyramid, have a lot of refined, and sometimes what we say is, no, don't have refined carbs, have complex carbs. And complex carbs in our definition is whole wheat, whole grain bread. And whole grain bread glycemic index, in my opinion, is no different than white bread. So as a nation, and this is the last real thing that I want to tell you, and then I'm going to stop. As a nation, we have high insulin levels and insulin resistance. So this gentleman is by name Joseph Kraft. He worked for 50 years at a Chicago hospital. He did 15,000 glucose tolerance tests, 15,000. So all of us do glucose tolerance tests, that's not a big deal. But in addition to doing glucose assay, every hour for 6 hours he did simultaneous insulin assays. So this guy is one of the stalwarts. He's one of my biggest heroes. He's 93. So that's a glucose tolerance test. When you do a glucose tolerance test, and if your sugar is over 140, you're considered to be a pre-diabetic. If it's over 200, you're considered to be a diabetic. So when you look at Kraft's data, of the 15,000 he did, roughly 9,500 had normal sugar levels, and the other ones were divided into pre-diabetic and diabetic category. But he took this and he said, if you are going to diagnose a diabetic based on their blood sugar levels with an oral glucose tolerance test, you're going to underestimate the true diabetics that are there. Because in my book, a person is a diabetic if they have insulin resistance. So he took these 9,000 people, he studied the insulin response, and this is the normal insulin pattern. This is the phase 1 insulin response, in which after you get a glucose load, your sugar goes up in half an hour, 1 hour, and then it comes down slowly over 4 hours or 5 hours. So in the 9,500 people that he checked the sugar levels, how many do you think had a normal insulin response? Less than 25%. So when you talk about diabetes being 20% in the US or hemoglobin A1C being 30%, it's a gross underestimation. I would tell you, in my practice, if I look at it, about 75% of us are insulin resistant. 75% of people amongst us are insulin resistant. So this is how Dr. Kraft defined it. This is normal insulin levels. This is the type 1 response. The type 2, the insulin goes up to about 100, comes down, and type 3, it goes up to about 150, comes down much more slowly. And there are certain type 4 people who are morbidly obese who go up to about 200. So I consistently demonstrate this in our patient population. So these are my conclusion slides, and maybe I'm going too far. I believe we have abdicated our clinical responsibility to key opinion leaders, big pharma, food industry, and various medical societies like American Heart, American College of Cardiology, and relinquished our critical thinking abilities. We subscribe to the food pyramid, which is a surrogate for a complex carb diet. We subscribe to the lipid, cholesterol, statin hypothesis. We are causing the obesity epidemic. We are causing insulin resistance. And in turn, we are causing heart disease, strokes, cancers, and dementia, not to mention diabetes. So this is the most difficult slide to put out there. Consequently, we as healthcare providers have to accept some responsibility as being the leading cause of death in the US and worldwide. And that is the sad truth. We have to take responsibility that we are doing this. So I want to change all of this. I want you guys to join me. Let's put together at Clear Lake Hospital a system in which we say, hey, we as physicians reject this and we are going to change your health not through big pharma and not through following the food pyramid, but we're going to follow different guidelines. Many of my patients go back to their PCP and their PCP tells them this, you went on Atkins, lost 90 pounds, lowered your cholesterol, cured your high blood pressure, and now you're walking 5 miles a day, but I'm warning you, this low carb diet is going to kill you. So that's the last thing. I think that understanding this concept that the diet heart hypothesis is fallacious, understanding this concept that low carb, high saturated fat diet is good for us is an idea whose time has come, much like Victor Hugo said several years ago. So thank you for being such a good audience. I appreciate it.
Thank you.
Yes, Jay, please, go ahead.
So you showed us that the low carb, high saturated fat diet, affects all the levels that you showed us. Is there data about if that has transformed or transpired into
mortality benefit?
Mortality, decrease in MI, decrease in stroke. So what's the point in taking in following this diet?
You make a very good point. What you are saying is that you are just giving me surrogate markers, and I don't believe in surrogate markers. I want to look at mortality data, and that is not there. So I don't know if there is an interest. The only way we're going to have mortality data is because no food industry is going to give you money to do these trials. No big pharma is going to give you money to do these trials. You're going to have to do it on your own. So until then, you're going to have to rely on epidemiologic data, surrogate data.
The question is, how can you convince your patients to follow this diet?
Oh, I have no problems.
They're going to ask you,
it's
going to help me live longer, or it's going to decrease my mortality, the stroke risk.
I have an answer for that, I can tell you. When my patients see that they have I have 90-year-olds who have lost 50 pounds. Not one, many. When they see that their weight is going down, that their hemoglobin A1C and sugar levels are getting better, when they see that they're having to take less insulin and less oral hypoglycemics, they believe me. So the amount of engagement that I have with my patients right now has never been, I feel like I have a purpose going to work now. When I used to go to the office, I used to hate it because I felt that I was ineffective. I couldn't do anything managing their blood pressure and stuff like that. Now I feel good going to the office and seeing 25, 30 patients a day because I feel I have a purpose. And I see that in my patients. My medical assistants see that in the patients. So they feel much more like they're contributing to it. I don't know, Brian, if you had a question.
What about in our indigenous society? How are we going to defend ourselves when we take them off statin?
You're so right. In Sweden, you're so right, Susan. In Sweden, one of the ladies who was prescribing a low-carb, high-fat diet was taken to the Swedish Medical Board, and she was sued. And the Swedish Medical Board, this happened back in 2008. The Swedish Medical Board, after looking at all the data, gave her a complete release. So yes, I mean, I have to fight this battle not just with my patients, and I have to fight it with the pharmaceutical reps that come to my office. I got to feel pretty bad when patients go to PCPs and the PCPs say, we don't trust in any of this data, you should not do this. Yes, Dr. Clark.
Quick question. I mean, this is a very complex situation. I give you credit for doing all these things.
2.5 years, BD.
It's a very complex situation. My question to you was, in primary biliary cirrhosis, I had a patient, she was 38-year-old, no other risk factors, no hypertension, non-smoker, just problem of primary biliary cirrhosis. Her total cholesterol was 900 milligram percent. I remember she had unstable angina. We cast her. I still remember we didn't have cath lab here. We had cast her at County Memorial. Inoperable multivessel disease. We transferred her to St. Luke's. They said, can't do anything.
That's 5.
How do you explain this lady with absolutely no other risk factors? Only risk factors is very high cholesterol level and then inoperable coronary artery disease.
You want to answer that?
Yeah.
Go ahead.
Because it's not about cholesterol. You're picking the wrong barometer.
Good.
The problem is not cholesterol. The problem is the inflammation that comes from the liver. That's where the cholesterol comes from. And it comes from the liver because the liver is inflamed.
I happen to agree with that, because when you go to a fire, you're not going to blame firemen for causing the fire. Cholesterol is an innocent bystander in my mind. But more importantly, there could be other factors. Maybe that lady had high levels of Lp(a). But even if I grant you that it is cholesterol, you're talking about a substance that is 5-fold the normal amount, 5-fold. You drop serum sodium levels to 100, people will die, 30% reduction. So when you take something to 5-fold, that I don't know if that makes any sense.
For he's talking about inflammation, but the theory, what we believe right now in atherosclerosis, is inflammation is induced through cholesterol molecules.
So,
Oxidized
but-
LDL enters the subintimal liver and starts the inflammation.
So
Inflammation starts the process of the migration into the endothelium.
No, any injury to the endothelium causes the migraine.
Well, the recent paper in Circulation that just came out actually this week, and they are throwing out, and this came out of Southwestern, and that's where I trained. You guys know I got my PhD in biochemistry. I worked with Jerry Mitchell and Jim Willerson, so the stuff that came out of Southwestern showed that they're throwing out the cholesterol. They came up with 5 tests to predict cardiac mortality and cardiovascular disease. One was a CT scan of the chest, which we've been doing in our office for a long time. So you showed calcium content of the coronary. And we've had to send patients to the operating room because we found them so clogged, and they had no other markers. The other one was a C-reactive protein, a cardiac C-reactive protein, the barometer for inflammatory changes inside the pipe. A high sensitivity troponin, there were 2 other tests. But everybody's throwing out cholesterol as a barometer for cardiovascular disease prediction. And that's where we're going with this. And, I want to congratulate you on this because I never thought I'd hear any of these words spoken in this hospital. And the rational processing of just basic biochemistry, this is how it works. This is what you can predict if you violate these simple biochemistry rules. And you guys know I was threatened to be thrown off staff if I ordered CoQ10 and vitamin D back in 2000. But what we see is exactly what you described, and we've been doing it for 20 years. We take patients out of here, we take them over where we can treat strokes with high-dose CoQ10, where their levels in cholesterol is 80. How are you going to make new myelin with a cholesterol of 80? I wrote a book chapter, half of which is dedicated to this on regenerative medicine. So everything you're saying is right on target, and I would love to spend an hour just telling you all of our experiences and our research in autism and how we've changed neurologic development with that. I think cholesterol is the biggest boondoggle that the world has ever seen. And I think that if we don't change our mentality and start thinking of what is the real etiology of cardiovascular disease and break it down to the foundation of where did the cholesterol come from? It came from this inflammatory change. What causes the inflammation? Well, that's multifactorial. So you got to figure out what in this individual is causing that. And carbs are the most likely cause. There's environmental causes, but it's got to be, you got to escape that cholesterol trap.
yes,
Question, I totally agree with inflammation, and we know, for instance, from all just that, for instance, pneumonia increases of acute coronary syndrome. A patient with pneumonia is more likely to have non-STEMI or even STEMI. So I totally agree with the inflammatory process that's involved in coronary disease. My question is, over the last maybe 10, 15 years, nationwide, there's decrease in the rate of stem in the country and all over. There was significant decrease in cardiovascular mortality and morbidity. Of course, we know that revascularization is the big umbrella or big factor in that. But patient who's like naive, they never had any cardiac workup, they are less frequently coming to the hospital with stent. And these patients who has better control of pressure, maybe aspirin, and maybe statin.
I would refuse to believe that statin is causing that. I think that's a little bit of a stretch. There were 2 trials that were done in unstable angina patient. The Miracle study and another study showed no difference in MIs, recurrent MIs, death. I would say that it's a myth that you say that the prevalence of cardiovascular disease is decreasing. It's increasing. We see an increased incidence of obesity. We see an increased incidence of diabetes. We see increased incidence of renal failure.
In the face of an average cholesterol being the lowest in the nation it's ever been.
Yeah, and I couldn't agree with you more. And if you look at the population data, diabetics will have lower average cholesterol than non-diabetics do. If you take out a population of patients with end-stage renal disease have lower average total cholesterol than patients who are out, other cohorts. Acute MI patients, when their cholesterol is measured within the first 24 hours, have lower average cholesterol levels than the rest of the cohort population. So it makes absolutely no sense to me that we are attributing a benefit to statins. Many of the people say these statins have pleiotropic benefits. And I think those pleiotropic benefits are very beneficial to the pharmaceutical companies. They cause cognition problems, muscle problems. They have no real vascular protective benefit, at least not that I could see. So, I'm being a little too harsh on there, but I don't know if that...
So what's the future of statins then? From where do we, what is FDA going to do? What is the American College is going to do and American Heart is going to do?
It's going to be impossible for these societies to come out and say, Dr. Ali, Dr. Turakia, we were wrong. Everything that we told you, please forget. It's going to be impossible. How are they going to retrace back?
No.
Do you know that
if these are scientific facts that were presented to them, then I personally feel that they have a responsibility, like you are talking, you and me have. They have a bigger responsibility. You're talking about nationwide.
It's all a question of bias.
They care about us.
Oh, excuse me.
and that they don't want any money.
Do you know how much Procter? Do you know how much Procter and Gamble gives to American Heart Association since 1970s? What does Procter and Gamble make? They make safflower oils, corn oil. So they want us to increase the intake of omega-6 oils at the expense of saturated fat. Do you know how much Merck and Pfizer and all give to the annual meetings of these billions?
Billions with a B.
What are they going to tell to these people? We are being controlled by big pharma, and the big pharma is controlling our societies.
Then why are you doing cholesterol? You keep ordering, isn't it?
No, I do cholesterol to evaluate the quality of cholesterol. And I tell my patients, your LDL level is high, your pattern A, please go home and celebrate. You have a better mind, you have a better memory, you're going to live longer, you're going to have lower cancer risk. So I say high cholesterol is to be celebrated, not to be mourned.
You forgot good sex life.
Thank you all.
What exactly is the mechanism of taking high saturated fat and lowering all the things that you're talking about? What's the mechanism behind it?
Because it's a biochemical mechanism. So what it does is that it reduces your insulin levels, and as your insulin levels go down, you become fat burning. And fat is the cleanest burning fuel there is. So when you So you take high carb diet, you will increase insulin production, IGF production. You take high protein diet, you'll get mTOR activated. So you will get aging, increased cell division, increased cancer risk. I can talk about this for about 2 to 3 days.
Are you putting all your patients on CoQ10 now?
Absolutely not. Absolutely not. Because to think that CoQ10 that you take by mouth is going to be packaged into a lipoprotein molecule, transported to the muscle cells, taken into the mitochondria is a stretch of imagination.
Okay.
Just don't give them statins.
Okay, don't give them statins.
Well, it gets destroyed in the stomach. You can't package it if you destroy it. You have to make it.
That is beautifully done.
Thank you. I appreciate it. DT, thank you for coming.